Matthew says, this trend to go through every possible adverse outcome with patients in advance is really not appreciated by most.
No.
Frequently, he says, he gets asked not to frighten them, but I have to tell them I'm required to obtain informed consent. We all know where this originates from, and as Laurie says, Matthew thinks it will change eventually. I don't know, we have to give patients that information, don't we? We can't go through with a technique, particularly in an especially vulnerable area, let's say the OA, without at least having given them the option to say no, I think. Yeah, I don't know how we phrase things so that we're being fair to the patient, but at the same time not frightening the bejesus out of them.
Yeah. I think it's a problem, and most surgeons will say, oh, if I do this, you may get a stroke. And we're not doing that, but we're almost going that way. And I think it's wrong, frankly.
Well, it's an interesting difference in frame of mind, isn't it? If I go to a surgeon to have a disc decompression, actually, I, as the patient, probably think this is the only option, and the surgeon knows what he's doing. I can understand the mechanics of this, so I can take his warnings not with a pinch of salt, but I can accept that he's going to do the right thing. When they come to an osteopath or a chiropractor, and they're given all that sort of detail, they're probably thinking, well, maybe I should go down the surgical route, where someone's going to cut through endless bits of tissue and risk all the consequences that does. But they think there's obviously no reason for you to do this when there's this level of risk. And we've had people on the show talking about how you explain that level of risk, and I sympathise with what Matthew says, because it's very hard to say the word stroke without causing people to get very upset, very worried, isn't it?